All right, welcome everyone to today's RISE webinar on population health management. We appreciate you spending the time with us today, as we know it's very busy for everyone. We'll start in a few minutes once everyone has had a chance to sign on. My name's Leslie McGeough, and I will be your host for today's webinar. I'm a focal point with RISE, and I work for Trillium Health Partners. Today's webinar is about population health management, a core concept for Ontario health teams. We used your feedback to develop today's session and heard how many of you would like to continue discussing co-designing care models for your priority populations. Today, we will hear from Michelle Rossi and Dr. Paul Kurdiak from the Mental Health and Addictions Center of Excellence, as well as Susan Blacker from the Ontario Palliative Care Network. They'll speak to common approaches and resources they offer OHTs as you co-design care models. We also heard from you that you want to continue developing connections and sharing ideas with each other. So as you join today's webinar, please add your name and organization and introduce yourself in the chat box. You can do this by selecting the right-hand portion of your screen, clicking chat, and selecting everyone from the drop-down. My colleague at RISE, Steve Lott, is also supporting us behind the scenes to ensure things run smoothly. If you do have issues with Zoom, you can message the host and he can help you resolve them. Welcome, Chris Wilson. Welcome, Christina Clark, one of our RISE coaches. Hi, Mike. Welcome. Glad you came since you're presenting. Hi, David. Nice to see you again. Welcome, Bianca and Cindy. Hi, Wendy. Oh my goodness, they're coming so quickly now. I can barely keep up. Dr. Harry from Burlington. Christina, welcome. Welcome to John Lavis, one of our RISE co-leads here today, and welcome to the other RISE Population Health Management coaches. I've seen you all join on. Hi, Abby, nice to see you again, Patient, Client, and Family Council. Hi, Jenny Gilbert. Welcome, Nadia from Burlington OHT, nice to see you here. Hi, Wendy Wu from North York, Toronto, and Jeremy Howcroft. Hi, Amy from Ontario Health. Please also feel free to share your Twitter handle or email so you can continue your conversations beyond today. We will also share a summary with you, including the emails you share in the chat box following today's session. Ours is posted on the slides so you can stay up to date on RISE events and resources. Following the session, we will also share a recording, the deck, and a one-page summary with the key concepts discussed today. As you join, please don't forget to introduce yourself in the chat box and select everyone from the drop-down so we can all see who's saying hello. Hi, Tiffany from Chatham-Kent, welcome. Hi, Tammy from Nipissing Wellness Patient and Family Collaborative Network. Hi, Deanna from OPCN, nice to see you. We also have discussion periods throughout the webinar today, so feel free to add your questions as they come to mind. You can also feel free to add any resources that you found helpful that maybe others could also.
Excellent, wonderful way to end. Thanks everyone.
We have our next meeting, we can talk about that.
Just get Steve to
Thanks,
mute
Rita,
that
for that. All right.
All right, so we'll give everyone, I think we've got about 78 participants so far, so I think we will get started. We would like to start today's session by acknowledging the land on which we work. As we work in Mississauga, we are using the Indigenous Traditional Land Acknowledgement Statement, which was developed by the Indigenous peoples in our region. As we meet here today, we are in solidarity with Indigenous peoples of Turtle Island and would like to begin by acknowledging that the land on which we gather is part of the treaty lands and territory of the Mississaugas of the Credit, and before the traditional territory of the Haudenosaunee, Huron, and Wendat. We also acknowledge the many First Nations, Inuit, Métis, and other global Indigenous peoples who now call this area their home. We are grateful for the opportunity to be working on this land. I'm now going to pass it over to Mike Hindmarsh, our head coach at RISE for Population Health Management, who will walk us through today's journey.
So welcome everyone, great to see everyone that's joined. You've seen this slide before, but you are moving along on this journey. So as you can see at the beginning, we talked about population health management, identifying priority populations, and how to think about segmenting those populations. And then once you have them segmented, you'll see that little triangle right there into whatever makes sense for the work that you're doing. You want to start thinking about care models and how are you going to design a system of care that meets the needs of the people in those different segments within your priority population. And to that end, we're going to be hearing from Paul and Michelle around mental health and addictions, and also from Sandra around Ontario Palliative Care Network. So they will help you with the care models that they're recommending people use. And then as you move along in this journey, and we're looking further into the year, you're going to be testing those models on a small scale and making sure that you have the models to a point where you can implement them without failure across the system. And that's where the journey that takes its little S in the road, because you'll be going back and forth testing that model and then moving towards implementation and evaluation. And this rather busy slide, but it makes a very good point about how you should be thinking about the work that you're going to be doing when you're doing co-design. So beginning with your initial population, priority population, the segments, you're thinking about how do we co-design models and what's it going to take in terms of system change that we have to do. So in one scenario, you may be having to build a whole new system of care to meet the needs of the population. In another scenario, you have an existing system that is working well for what it was designed to do, but you need to tweak it basically to make sure that it's going to meet all of the needs and meets the gaps in care. And then the other one is that you might have an existing structure that is working just fine, and you want to make sure that it continues doing that. I read those a bit out of order, so I apologize. You're going to have action teams and working groups. Our coaches have been sitting on many of these action teams and working groups with cohort 1. We're just bringing on cohort 2 teams, and hopefully they'll be putting together the same kinds of things. And then, as I said, once you've tested your models of care or tested the systems that you put in place, you want to think about how do we then move to implementation. And when you ramp up to implementation, you want to make sure there are no system-wide failures, even though you'll have to be testing how do I do an implementation across the whole priority population and across all of the organizations that are involved in the care for that organization. Let's go to the next slide. Just want to make a distinction here. Quite often in the literature, you'll see these two phrases being used interchangeably, care pathways and care models. I think it's important that we make a distinction here between the two. When we are talking about care models, we're talking about a system of care. What needs to happen to all the pieces and all the organizations involved in an OHT in order to redesign themselves to meet the needs of the priority population. So what changes does a hospital have to make? What changes do primary care and specialty care have to make? Are there changes in community social support programs that need to be made to manage the population? When we talk about care pathways, that's really more of a clinical concept around how do we actually manage a patient with a particular condition. So quite often you'll see algorithms for how to manage, diagnose, and manage COPD. And it'd be a very clear algorithm. You know, patient presents with symptoms, patient is, do the symptoms appear to be COPD, send patient to spirometry, positive, yes, no, and so on and so forth. So care pathways are really more of a clinical concept around how do we actually manage the patient. So I just wanted to make the distinction between the two. You'll hear us talking more about care models at this point, but it may be that you have to design some care pathways within your models of care. Next slide. And then we have to ask ourselves, well, what are the core changes and the concepts that we need to address in order to create this OHT, this system of care that is built around the patients? And there really are 5 key core concepts. You've got to think about how you do delivery system design. So people need access to care. So you might need to redesign systems, whether it's in the hospital, primary care, or elsewhere, to get access to care. People will need care coordination depending on the severity of their conditions. Some will need a fuller court press around care management with more severe and complex disease. Some patients just may need some care navigation, how to move around within the new system. So that delivery system design piece really is how do we change our current system, which really was designed many years ago to manage more acute care issues like short-term infections, disease, injuries, that sort of thing. But the influx of chronic conditions as well as mental health conditions really requires us to look at our system and say, okay, how do we manage these new types of populations? And new is a relative term. We've been working with this for almost 30 to 40 years now. You want to make sure your clinical decision supports are in place. It's easy to get to evidence-based guidelines. You want to make sure that there's good communication between the different parts of the OHT. So when patients move around in the system, their information moves with them. You want the information technology to support that. So EMRs are just one piece of that, but we need to make sure that all aspects of the OHT are talking to each other and sharing information about the patient so that the patient doesn't have to repeat their story everywhere they go. You want to be delivering self-management support to patients. We talk in the old language about non-compliant patients, and really what we're talking about here are patients that don't have the confidence to take care of their health. They either have health literacy issues, but they may not know how to take their medications. They may not fully understand their condition or even know that they have a condition. So we need to be able to provide behavioral support so that they're able to think about how to build their confidence to manage their health. And then tying into the community resources. Now that's just part of the OHT. You're going to be looking at not only community referral agencies where you can refer people for certain chronic conditions or certain mental health conditions, but also those agencies that provide social support. Social determinants, as we know, are directly linked to health outcomes. So a big part of your OHT will be connecting with those social support organizations that can help patients with their social determinants. And the next slide. So with that recap, what we'll do is we'll move to our first presenters today. I'd like to introduce Michelle Rossi and Dr. Paul Kurdiak. They're going to talk to us about mental health and addictions. And I'll hand it over to you, Michelle.
Thanks a lot. It's really nice to be here, and it's nice to be able to talk to you all about the new Mental Health and Addiction Center of Excellence at Ontario Health and its mandate, and a little bit about how we're thinking about population health approaches in the Center of Excellence's work. So I'm going to kick us off, and then Paul and I will pass this off between the two of us. Just really briefly on this slide for those who might not have been following along as closely as some of us in the government agency world have. This is kind of how we got to where we are today. You know, there's a connection here between the government's decision to create Ontario Health through the Connecting Care Act. And at the same time that they were doing that, they also introduced some legislation to support mental health and addictions in the province, including an act called the Mental Health and Addictions Center of Excellence Act. So that act was proclaimed back in February, just over a year ago, and establishes the requirement for Ontario Health to have an entity called the Mental Health and Addiction Center of Excellence, and it sets out the core mandate of the center in that act, which is really around operationalizing provincial strategy around mental health and addictions, and activities like developing clinical quality service standards, you know, measurement and monitoring and reporting. And then there's also a component of the mandate around providing resources and supports to OHTs, in fact. So while that was all underway, Ontario Health itself was forming, and I think this might be the only place in our slides where we've used acronyms because I couldn't cram them on, but you know, the agencies, the Cancer Care Ontario and Health Quality Ontario, eHealth Ontario, Health Force Ontario, and Health Shared Services Ontario, which was the sort of back office kind of corporate functions for the LHINs and the home care system sort of transferred in. So we've kind of had Ontario Health under construction, and we've been establishing this new Mental Health and Addiction Center of Excellence within the new agency. And then we really sort of were able to get going about a year ago in March, just as COVID was kind of arriving, or we were becoming really aware of the implications of that with the launch of the government's roadmap to wellness. And I think if you've identified that mental health and addictions population as a priority population for you, and you're not yet familiar with the roadmap to wellness, it would be a good document to review, because it sets out what the priorities and plans are for building a more connected, I think they call it a more comprehensive, coordinated mental health and addictions system. So there's a lot of important priorities and some populations who are mentioned in this document. And really it describes the Center of Excellence as serving as the foundation on which this strategy will be built, and serving as the central point of oversight and accountability for the mental health and addiction system in Ontario. And the idea here is that we will be leveraging all of the assets and capacity that have been built in the constituting agencies of Ontario Health, and bringing those to bear to help with working with other partners put into place a better system for mental health and addictions in the province. So on the next slide, I wanted to also add this slide in because we have a legislated mandate. We've got we have some pretty clear deliverables from the roadmap to wellness, but I think the third kind of component that we really look to in executing on our work is Ontario Health's equity, inclusion, diversity, and anti-racism framework. And we have a very strong commitment to ensuring that there is a kind of an equity-focused foundation to the work that we're doing. I know the mental health and addictions population in and of itself is often an equity-seeking population, but we know that even within that population, there are many groups that we need to pay careful attention to ensure that they don't get left behind. And really, if we want to move the needle on the performance of our system, we really have to make sure that the people who are sort of most poorly served right now are actually achieving better outcomes. So this is a sort of just the placemat of the framework. There's a full kind of document on the Ontario Health website, but we also have really embedded this into the approach that we're taking to our work. The next slide is over to Paul.
Okay, thanks, Michelle, and thank you, Mike and Leslie, for the invitation today. I'm not going to read every point, but the point of this slide is to say that, especially in relation to the time I've spent within Ontario Health, that there is a certain playbook that is universal, whether you're talking about cancer care, renal care, palliative care, that the successful, that areas of the healthcare sector that have been successful in this programmatic approach. And it involves the kinds of things that we'll be talking about, which is clinical leadership, regionalized access, analytics, this learning health system concept of iterative learning, which involves outcome monitoring. And and the reason I'm stating this up front is that, to address the resistance that somehow mental health is different. And I'll talk about it later, but for sure, like, you can't apply a programmatic population-based approach to the entirety of mental health and addictions because it's much too diverse a population. But there are certainly subpopulations, identifiable subpopulations for which that's applicable. And that's what I'll be focusing on later on. Back to you, Michelle. And the next slide.
Sorry, I was muted there. Some of our early priorities that arise from the roadmap to wellness really revolve around, setting up a mental health and addiction center of excellence within Ontario Health and pulling in those lessons learned from other provincial programs. We have an initiative underway that Paul will reference a bit later in the presentation about expanding access to publicly funded psychotherapy in the province. This is a program that has been operating in a pilot form for the last few years that's being expanded now. we have some big data and digital infrastructure implementations that are underway, and we hope that this is really a foundational component of building a better system and providing support to clinicians, to health service provider organizations, to system planners, where we can really embed that concept of sort of collecting data once, but using it for many purposes, including system planning, this better understanding of demand and utilization of services, and better understanding outcomes among different populations and costs, and ultimately also supporting improved system performance monitoring, program management, and quality improvement efforts. And the last piece that we're working on is really around this notion of core services for mental health and addictions, and beginning to put a structure in place so that we can systematically identify high prevalence or high priority populations, and we can sort of like carve out those populations and begin advancing improvement in the services that they require to get better outcomes. And this really pulls together all of the aspects of that provincial kind of that playbook that Paul was mentioning, that we've seen be useful in other provincial sort of clinical domains, and applying this kind of provincial program model in a strategic way as we look at the populations that we are really wanting to improve outcomes for. So the next slide is just a quick view. This is literally a snapshot of the core services framework that was included in the roadmap to wellness. And I don't want to create the idea that this is done. This was sort of an example that was included in the roadmap, but I think it speaks to the concepts that Mike was talking about, and where the roadmap kind of emphasizes the need to understand the needs of the population and the services that should be available to them. And we have some work to do to refine this framework and to consistently define the services and the populations that, using best evidence, understanding where services are available and to what level of quality, and then ultimately build on this to put plans together to kind of remedy any gaps. So this is a work in progress, this sort of attempt to have a framework for mapping out population need and the aligned services. And I think this will be highly relevant to the work of OHTs that are focusing on this population. And so this work is underway now, and we'll be expecting to see it in a more mature state over the coming year. And we'll move to the next slide. And so finally, this just again returns to that concept of we sort of know at the provincial level what we are hoping to build more capacity for, and this is to Paul's point around having a provincial sort of clinical leadership model and having the right type of engagement structures, ensuring that we're bringing good evidence to bear in the right places, and this includes qualitative insights. As I mentioned, the importance of the data and digital infrastructure that ties into being able to monitor and manage appropriately, and measure and report. And then finally, I think this issue that around, we've called it here integration and coordination, but really speaking to that point that was on the earlier slide around sort of the importance of access and system navigation, especially in this fairly complex domain of healthcare delivery. So we sort of know, like the cake at the bottom, we know what most of the ingredients are, but in mental health and addictions, we don't quite have the recipe to bake the beautiful cake. So I think this is part of the work that we're undertaking with our array of system partners, is to kind of refine this model and together figure out how to best apply it in mental health and addictions. And it's essential when we think about this, although we do have the Mental Health and Addiction Center of Excellence has a provincial mandate, the regional presence, the kind of local execution, all of these levels are essential and need to be working together in concert. And it's really, it can be a very powerful I think, kind of change agent to be able to say, this is what we're seeing, you know, on the ground at the local level, and this is where we kind of need support from a broader provincial health system perspective. Let's do it once and everyone can benefit from it. And then it can also be very powerful from a provincial perspective to have that effector arm, you know, right down to the delivery site. So it can help implement proven interventions that we want to have implemented to a certain degree of fidelity across the whole province, but it can also be a really interesting way to support innovation and to deploy kind of innovative models and test them out, and then have an effector arm for spreading and scaling. So we talk about this provincial model, but it's really not just at that provincial level. We all just really need to be working in concert to have the greatest effect. Now I'm going to turn it over to Paul, who can walk through a bit of an example of something we're doing in real time around a particular population.
Thanks, Michelle. This is just sort of outlining kind of some of the steps we're thinking about in terms of our approach. And the first point is that you have to understand the needs of the population. And when we talk about population, we're mostly thinking about clinical domains like depression or alcohol use disorder or things like that. And then you've had to figure out what kind of services are available and the resources invested to meet the needs. Then you have to figure out whether or not those services are actually responding adequately to the needs of the population and achieving the intended outcomes, and the arrows are supposed to be a little expanded, but it's sort of the iteration in the learning health system. You know, plan something, do it, determine whether it meets the outcomes. If not, go back and try again with evidence-informed improvement processes. And then you align investments to fill gaps, and then you just keep going until you achieve what you'd hope to achieve in terms of meeting the population needs. Next slide. Yeah, so this was just to say that we've worked with Walter Wojcicki and Ruth Croxford and they've developed some of the indicators that at OHT level that we've developed at ICS, and those showed some pretty significant variation, but they're pretty big dot, right? So 30-day readmission, you know, emergency department revisits, et cetera. It's really hard to know what to do from a population-specific perspective in the mental health area. And these are the issues that I'm guessing that a lot of the OHTs are struggling with, that mental health and addictions is really diverse, that there are child-specific disorders, there are sort of geriatric and elderly-specific disorders, and then there are disorders that span the whole lifespan, but probably have different issues depending on the age at which an individual is dealing with a particular disorder. So for example, you know, somebody who's dealing with depression at the age of 19 has a very different experience of that depression than somebody who's dealing with depression at 60, when there's sort of issues impacting medical comorbidity, et cetera, et cetera. There are many, many different disorders that map onto different populations, so you can't really approach everything at the same time. There are different types of interventions depending on the type of disorder. So there are, you know, evidence-based psychotherapies for depression and anxiety, different types of psychotherapies for things like borderline personality disorder, and then addictions has its own set of evidence-based interventions. So there's quite a bit of variability in what you should do. And then, you know, each disorder has its own way of presenting itself across the severity spectrum. And the one thing that I wanted to emphasize is the population-based and programmatic approach is more important than the population of interest. It really doesn't matter what you choose, although I would say that there's probably opportunities as OHTs evolve provincially to focus on one or two, to have the sort of communal learning and community building across the OHTs on how one approaches, say, depression or alcohol use disorder or some of the other high prevalence, high impact conditions. Next slide. But I'm going to just focus on depression as a population of focus to start with, and to say that there is a real burning platform for depression. It's extremely prevalent. It's one of the most prevalent disorders. It also has incredible burden. It's one of the most burdensome illnesses, not because people die early from it, but because people acquire the disorder at an early age of onset. And then if untreated, depression has a high cost on quality of life and burden in terms of lower functioning across the lifespan, which I would argue is a better case for intervention. So if adequately treated, you could spare somebody a lifetime of burden. We know from the Statistics Canada data that only, as of the more recent data, only half are properly diagnosed, and there's even more variability in the quality of treatment. And there's certainly huge variability in access to specialty care when needed. And we also know that untreated depression causes incredible disability. And we also know that people with medical comorbidities who have untreated depression also have a far harder time at the kind of self-management that lead to good outcomes in conditions like diabetes and cardiovascular illness. Next slide. Okay, so what is the opportunity? Well, for one thing, this has been done. So Mike, coming from Seattle, will be familiar with some of the groundbreaking work that has been developed in the US and is now being scaled and spread in many jurisdictions in the US, and that's team-based care or collaborative care for depression. So there is a playbook on how to do this. And the other really interesting opportunity is the fact that we're in the midst of scaling and spreading a provincial cognitive behavioral therapy program for mild to moderate depression. I'll go on to the next slide, which I believe is my last slide, just to say that if you were to focus on depression, we expect in fairly short order that there will be regional access to evidence-based, cognitive-based therapy that will be measurement-based care that will be accessible so in other words, if you identify somebody with mild to moderate depression in your OHTs, we should have regional programs that you can refer to and then to get feedback on if you were to do so, in addition to whatever you might do within your OHT in terms of setting up algorithmic evidence-based pharmacotherapy for depression, for example. And the other piece is that once you have these processes in place, then you have sort of a pathway that, especially if you do measurement-based care, that aligns with specialty care. So the people who don't respond to your medication algorithms or CBT or both are those that should be going to specialty care within your OHT. And this is some of the sort of the ingredients we are working on to build the OSP cake, the structured psychotherapy cake. We're thinking through centralized access. It's a hub and spoke approach where we're going to have a regional network distributing oversight of care in satellite sites. Really robust evidence-based training and program guidance, and there's ongoing oversight and clinical consultation. And of course, the really important piece that we're working on is the data infrastructure to do the measurement-based care to determine whether people are getting what they need and figuring out what to do if they don't. And I think that's the last slide. We'll stop there.
So thank you so much, Paul and Michelle. I think if I can just sort of do a very quick teach back, what I heard from you is you gave us some of the history of the development of the Center for Excellence and the mental health and addictions work that's being systematized across the province. You talked a bit about the need to, well, the diversity of the mental health population and the need to target your segments accordingly. And also you mentioned that a good place to start may be dealing with depression care in its manifestations anywhere from mild to severe, and then how to move forward with that treatment of that, as well as having access to a provincial-based cognitive behavioral therapy program. Did I miss anything? Any key points that I missed there, Paul or Michelle?
No, that was good. A really good overview, Mike. Thank you.
Type your questions into the chat box, folks. We have a couple of minutes for questions for Paul and Michelle. As I mentioned in an earlier chat, if you don't have questions or you think of questions after the webinar, contact your coach and we'll make sure you get answers. Paul and Michelle are here for the long haul in this transformation work and are here to support you. Paul, I have a question that actually came up in a group that I was on call with just before, and that a lot of severe mental health shows up in the ER. And especially since COVID, the numbers of people showing up with severe exacerbations of mental health issues is increasing, as well as inpatient admissions. Any guidance for folks?
Yeah, so I think what's happening here, and we haven't yet seen it in the administrative data, so a lot of this is anecdotal. I can tell you what we've seen in our monitoring, which goes now to December 2020, so it's not as up to date as now, is a slight uptick in outpatient visits post-pandemic, but in adults and not in kids. That seems to have attenuated back to baseline. And no real change in, like there was a drop immediately in March and April, no real change in emerge visits or hospitalizations for mental health and addictions regions, with a couple of exceptions, that one of them being eating disorders. There's a big signal there. I think what we're going to see is what you signal, which is we're starting to see the impact of treatment avoidance and or treatment lapse. And what I mean by treatment lapse is, with this massive shift to virtual care, I think that there are the more vulnerable and or more severe forms, segments of our population, like people with like severe forms of schizophrenia. I don't know how they would have navigated, video conferencing or even phone-based management. I don't think that's sufficient. So they may have dropped off a cliff, and we might be starting to see them coming to the emerge just in crisis, brought in by police, et cetera, et cetera. And then a treatment avoidance is volitional, but it will have its consequences as well. So I think that unfortunately we're going to have to be a little bit reactive, because I think this is all anticipated consequences of the shift to virtual and the way we had to do things differently. But in the middle of a pandemic where it was just hard to do everything, and certainly within the Center of Excellence, we were really trying to bring focus to this. But it's just with hospitals, everybody was scrambling to focus on COVID primarily. I would say that one of the obvious things is to put a kind of a vulnerability frame on the populations you're serving, and kind of try to think about the people who you've lost contact with and try to intervene. And also, I would say that the importance of wraparound care when people do come to the emergency department, when you discharge them, is even greater. We know from our measurement that the likelihood that people get care after the emergency department visit, even if people are in crisis, is very poor. Like really making those transitions much more, and working harder. I mean, you have to work harder for the kinds of people who are coming to care to make those transitions stick. But this is all, I mean, and the last point I say is this is just an exacerbation of pre-existing weaknesses and vulnerabilities in our mental health framework. So this is not new, it's just exaggerated, I believe.
That makes good sense, Paul. We do have to go to our next presentation. If I could ask Paul and Michelle to look at the chat, and if you're able to answer some of the questions that are in the chat. We've got questions from Nadine and Abigail. There's quite a number of them that are coming in. So if you could possibly look at those while our next presenter is presenting and give people some guidance or some information, that'd be terrific. What I'd like to do now is introduce our next speaker. We go to the next slide. Yeah, thanks. I'd like to introduce us. Sorry, Susan, I called you Sandra earlier. I'd like to introduce Ms. Susan Blacker from the Ontario Palliative Care Network, and she's going to tell us about the model for palliative care in Ontario.
Great. Good afternoon, everyone. Really pleased to be here on behalf of the Ontario Palliative Care Network Secretariat. I'm one of two provincial clinical co-leads. So my colleague, Dr. Darren Cargill, is the other provincial clinical co-lead. And it's terrific this afternoon to have an opportunity to give you an overview of some of the work that we've been doing through the Ontario Palliative Care Network, but probably even more importantly, to review with you some of the resources that I think will be really helpful in the work that you're doing around planning your approaches to your OHT and really thinking about system transformation. So if we could go to the next slide, we always find it very helpful to just contextualize for everyone, what do we mean when we're talking about palliative care? Because all too often we find when groups come together, the conversation may be getting very limited in people's thinking around that inner circle, which would be terminal care when individuals have just hours or days left to live, or perhaps more commonly end-of-life care. But we really want to encourage everyone to be thinking about palliative care in the broadest of terms, because that's where the greatest potential is for us to really make an impact on our system and how we are serving individuals and families who are living with serious and life-limiting illness. So the information I'm going to share with you today is very much grounded in that broadest way of thinking about palliative care. So the next slide is just going to give you a little bit of orientation to some of the work that we've done and some tools that you'll be able to go onto our website and find that I think will be incredibly helpful in many of the conversations that you will be having. We were asked to talk a little bit about how do you begin to think about who your segment of the priority population is. And in palliative care, we talk a lot about the challenge, but also the important opportunity to be identifying needs earlier in a patient's journey and in the course of their receiving care. So one of the tools that you will find is called Tools to Support Earlier Identification of Palliative Care. It's a toolkit that recommends a number of evidence-based tools. It also recommends what settings they can be most appropriately tailored to, so that you can really be thinking about how our teams identifying who has unmet palliative care needs, and how do we begin then to think about what that system of care needs to look like in order to address those. That takes us into the next section, which is really, back to the slide, please, is really then understanding what is it that we're needing to do in terms of developing a system and implementing a model that's going to allow us to successfully address the needs of the population. We've done the work for you in terms of creating the Palliative Care Health Service Delivery Framework. This is the first of what we hope will be one of several models or frameworks, but it is tailored for those adults who are living in the community with life-limiting illness. The recommendations, and I'm going to take a few moments today to go through those for you, are really very practical and intended to give you good starting points for your conversations around how do we need to think about, and I appreciated the distinction that Mike made earlier in the call, both the care pathway, so what does that need to look like for the patient, who's involved, what are the processes, but also what that overarching care model needs to look like. And so important to know, we've done a lot of stakeholder engagement. I'm going to tell you a little bit about the regional palliative care networks and the work that they've done around this in a moment. But so much of the work is really well articulated for you in this document already. And so we hope it will allow you to leverage the pathway to really identify both community resources, but equally as importantly, when we're talking about that broadest definition of palliative care service delivery, to think about all of the important cross-sectoral partnerships that need to be addressed to identify palliative care needs. We recognize the incredibly important role that hospices play, and hospice might mean, a service or an organization that is going into patients' homes and providing services there. Could also mean a place or a residence. It's talking about home care, but we also need to think about all of the individuals who might be involved along the continuum of care for that patient, and clearly identifying who the team is at any given time. I'll speak a bit more about this because the importance of care coordination in this is of paramount importance. Finally, the last document that's listed here is the quality standard for palliative care. And this is really helpful in terms of being able to think about at the team level, the organization level, the system level, how would we know that we've now achieved high quality palliative care? And so this document not only has the standards stated very clearly, but also talks about how we could implement indicators to know that the system is working in the ways that we would like, or have some opportunities to monitor where those ongoing opportunities exist for improvement. So if we could go to the next slide, I do want to make sure that you know about the regional palliative care networks that exist. There are 14 across the province. These will all align with the original LIN structure. And in those RPCNs, there's a network director and 2 clinical co-leads. This structure is really important because we've put this in place in order to facilitate the implementation of all of the tools that I'm sharing with you today. And these networks have been already spending a lot of time thinking about where are the opportunities for enhancing and augmenting the palliative care system, and have been thinking about that in very local ways. So we're really strongly encouraging, if you haven't reached out and made a connection to your regional palliative care network, please do. My colleagues, Deanna Bryant and Tara Walton from the Secretariat are on the call, and we're going to make sure that we follow up on any questions that come through today, but also that you've got an email address so that you can reach out to us and we can help you get connected to your regional palliative care network leadership so that you can go forward with the work. Important to recognize that not only do we see these as a really critical mechanism to support OHT work, but also the RPCNs are the holder of some really important and valuable local data. So we talk about the big dot indicators for palliative care, but we also have been providing for some time now more at a sub-regional level data around the system and how it's working. And so if you haven't had an opportunity to connect with the RPCNs around that, that will be a very valuable starting point. It's important to also have the RPCNs give some guidance around how to ensure alignment of the OHT work with the provincial direction. And we think that there's just a real opportunity to minimize duplication and really maximize the work so we can all move this important work further and faster. Next slide, please, Mike. So you will see in the health service delivery framework, we've taken great care and really done a lot of engagement with stakeholders to describe the model of care and the team that's providing that, with obviously patient and family or caregiver centered to that. Care coordination is clearly foundationally important. This doesn't work well without a strong emphasis on care coordination. And we spend a lot of time in the delivery framework really articulating what that needs to look like, what are the core components of that. So it will be very helpful information for the team to review and think about as you're imagining the possibilities for designing or augmenting your existing systems. We talk about the core team. So for some patients and families, that is primary care. But in other instances, that might be a specialist team. It could be their oncology team. It could be nephrology. But needing to really determine and sort through who's the most responsible prescribing provider. At the next layer, we talk about extended services. And so this may be when a patient's condition has changed to the point that they're now receiving home care. They may have hospice services coming in. They may have some rehab professionals involved in terms of assessing safety in the home and putting equipment in. And on that outer layer, there is certainly a role for palliative care specialists. But this is an important distinction. We talk about the palliative approach to care, and then we talk about palliative care specialist services. So for many patients, that will be a resource that's important in their care. It may be in terms of providing consultation. It could also be the team that's responsible for providing direct care. But if we're truly using that broadest definition of palliative care, this may change for any individual patient or family over time. And it's very important to think about, how does that work in your system today? Where are there gaps? Where do those transitions in terms of responsibility happen? How well does communication work? So we hope that this will be a really valuable way for your teams to be thinking about imagining your system of palliative care delivery. The next slide is the patient pathway as we've mapped it out. And the top boxes of each of these columns really identify the core elements that need to be well thought through in terms of designing a system. And so this could be a very helpful tool in terms of your team meetings and talking about it and describing current state and where do you hope to get to with future state. But the other piece that I want to make sure we call out today is the recommendations component of the health service delivery framework. So if I could go to the next slide. There are 13 recommendations, and really working through them sequentially would be a very important and helpful starting point. So you'll see recommendation 1 is determining who the patients are who would benefit from palliative care earlier in their illness course. And that's where the toolkit that I mentioned earlier can be very, very helpful. There are 13. There's a lot of narrative that we've included in the delivery framework document around what these would need to look like. They each have sort of sub-recommendations. We've already had the regions identify where they feel the priority starting points need to be. And generally, we heard a lot of consensus around 1, 2, and 3 as the gaps, but also the foundational elements that only once those areas have been well addressed and designed in terms of the system, will the other pieces then fall into place. The other gap that we heard is related to number 6 and 7, which is really touching on how well are patients and families supported from an emotional, psychological, spiritual care perspective, and in terms of receiving care in a very culturally safe manner. And so those won't surprise you when you hear them come up, but they have been already identified by the regions as some of the areas of greatest opportunity. So we can probably skip over the next slide, although we might want to just show it for a moment so folks get a bit of a sense. The other points that I will call out from this particular slide is recommendations 10 through 13 really do have some suggestions and some ideas tied to them around patients who are living in long-term care homes. Recommendation 11 was developed through a lot of consultation with leadership from our First Nations, Inuit, Métis, and urban Indigenous communities in terms of thinking about palliative care and how that needs to be developed collaboratively and delivered in a culturally safe and sensitive way. Recommendation 12 talks about French language services. And finally, number 13 is really looking at those who are homeless or vulnerably housed. So touches on some of the things that Mike was talking about earlier around the importance of social determinants. And I think we've got one more slide. So these are the links to all of the resources that I have just described. The data that I described earlier, you would obtain from the regional palliative care networks themselves. And we really hope that these will be helpful, and we're really delighted to give you a whirlwind tour of the tools that we've got available through OPCN, but we would be pleased to meet with teams, make sure you get well connected with your regional networks, and to give you a deeper dive into any of the tools that we've talked about today at future points.
Great. Thank you so much, Susan. I'll attempt to teach back with this too. I think what I heard very loud and clear is that OPCN has thought through very carefully what the model of care would be for people with palliative care needs, and thought through the segments of the population, not only within the palliative care segment, but also when we look at end of life and those that are at the terminal stage of life. I very much like the care model with the pathways underneath it. It's a nice distinction, and hopefully is very useful. And there clearly are the recommendations that would help guide your improvement work that Susan talked about. I should also note in the chat that there is a tool on the RISE website for identifying people with palliative care needs. The tool is designed for primary care, which is a great place to start in terms of how you might want to segment the population, looking at those people that need palliative care, not identified currently in primary care, and start working through your segments that way. Anything I missed overall, Susan?
No, I think you did a great job summarizing. Thank you.
Thanks. Again, there's lots of questions coming in the chat. We have a minute or two for a couple of them. Maybe Susan, if you can look at some of them, and I'll read out. Let's see. Just trying to find one here. My chat is misbehaving. I try to scroll up.
Mine is too.
It jumps all over the place.
They know Dina and Tara have probably been watching them too and responding where they can be helpful.
There's a question, Mike, around whether or not the 14 RPCNs organize themselves in part by OH region. And would
Yeah, so
part two.
Anytime talking about our governance structure, but the important takeaway is that the OH leads are part of our executive oversight for all of this. And so, yes, the RPCNs are closely connected geographically to the 5 OH regions. I think Deanna might have touched on that in a response in the chat.
And there's also with respect to the identification tool, and I'm probably not going to do a very good job pronouncing your name, but Larige has posted that there's a case study of the use of the digital health tool. So I would encourage you to look at that and see the effectiveness of the tool. The OH folks. Any other questions for Susan? Let's see. Just looking at some of these. Okay. I think we're coming up to the top of the hour. So again, we will, if there are questions that weren't answered, we'll make sure we get them answered for you. I'd really like to thank Paul, Michelle, and Susan for your presentations. There's a wealth of information there. And in my opinion, a wealth of ideas for where to get started with these populations if you're just at that point of thinking about what our care models should be. So again, thank you so much. Leslie, I'll pass it back to you for a wrap up. Oh, very good.
Okay, we'll skip over your slide, Mike.
Okay.
So just a couple events we wanted to bring to your attention. We have booked our next webinar, which we're excited about, for June 17th. So you'll notice we're starting to do lunchtime the third Thursday of each month. Our next webinar will feature Health Commons Solutions Labs and speak about health inequalities and how to address those across your populations. Also for cohort 1 and cohort 2 working group leads, there is a June 1st collaborative discussion session booked for you. If you would like to be involved, please contact me directly. My email address is here. And of course, as always, sign up for the collaborative groups down here on the bottom, and you'll be automatically notified about any of our upcoming events. So following today's session, we will post all of this on the RISE events page, including a recording and a one-page summary to follow. So you can access these links and email addresses. Thank you everyone for your time today. We appreciate you participating and joining in the chat. And thank you so much to our guest presenters for sharing all these great resources. Hope you have a great rest of your day.
Take care, everyone. Thank you.